ResMed pulls out of North America, and let's just advance a bit to that part of the slide. And all of a sudden, Pantera had this increased demand that meant they had to sort of put this on the back burner. And that's fine. So as you know, a few years have passed, and now they're finally ready to launch it, and they were going to be launching it at their Pantera Days conference in June. And now COVID has put an end to that conference happening. So once again, that X3 is not going to launch as planned. However, they're ready to do this. So I imagine sometime this fall, I don't have the official word on this, this appliance will become available, at least in North America. So we'll be talking about that appliance today. And then also, I have a surprise appliance that's brand new. I highly doubt anyone on the blog today has seen even pictures of it. It's so brand new. And this appliance will be available in Canada, is actually already available at the soft launch in Canada, and will be going to the States. So I would say that Dental Services Group is the rep you want to talk to about having access to this appliance once you see what it's all about. So CADCAM design manufactured, computer-assisted design, computer-assisted manufacturing, and it just changes everything because it allows very quick innovation development. A dentist can say, oh, I wish you had this feature, I wish you had that feature. And all I have to do is they talk to computer technician that sits there next thing you know, they have that feature. It's amazing compared to the old days where you would have to throw out all the molds for your device, the component, the advancement mechanisms, and redesign it from scratch and then create a whole bunch of new molds. I mean, advancement, enhancements, changes did not happen so quickly there. You would have things on a wish list, and eventually once you recovered enough money from the making of these molds, you would then be able to invest in making new molds with some advancements and come up with a new version of your appliance. Here, you can have a new version of your appliance on a weekly basis. You're just changing software. Now, of course, there's some testing involved, but tweaks can be done very quickly and very easily because of that CAD/CAM environment, which is one of the things that makes it very special. The other thing that makes it very special is this type 12 polyamide nylon polymer, okay? Laser sintered manufacturing, 50 microns of exactness, strong, comfortable, compliant. It's been used in the medical field for a while. Digital storage of patient records allows for additional replacement devices made without taking new impressions. Of course, this applies to any CAD/CAM, even the acrylic milled appliances. They are not repairable. So as a result, the companies right out of the gate had to sort of provide, reasonable warranty on breakage for peace of mind for the patients. So you can see the current warranty for breakage for the Pantera is 3 years. X3 would be also 3 years eventually when it's out. Juventus is 3 years. DDSO, 5 years. Now, the difference for them is that it doesn't matter when it happens during that 5 years, there's a $100 printing fee, even if you lose the appliance. So in essence, basically it's like having an insurance policy. For 5 years, it'll cost you a $100 deductible to get a new appliance. Now, I'm not clear as to whether you can only do that once. I think that's the case, but these things are changing all the time. So that's something that you'd want to just confirm, before you repeated that. So when I was first introduced to this type 12 nylon, a gentleman named Rob Suter and some other reps from ResMed came to visit me at the office, and they showed me the new appliance ResMed was bringing to North America. And I literally laughed. I thought, this is so flimsy, this toy. Are you kidding me? We're gonna actually, this is the best ResMed could do, were the words that came out of my mouth. Well, Rob looked at me and says, well, you feel that way because you don't really have an appreciation for this nylon material. And he was 100% right. That was the first nylon appliance I've ever seen. I had no understanding of what it was. It looked like a little Halloween toy, you know, the little white fangs that, you know, a child would wear. It didn't really look like a real medical device. It didn't look robust at all. It looked flimsy. It looked cheap, you know. Relatively speaking to the nice, robust appliances we've been making, the herps, you know, with, you know, stainless steel components and all this stuff. Well, I went into industry literature, nothing to do with dental, and I looked up this type 12 polyamide nylon to look up what the characteristics of this material were. And this is what I found. Absorbs very little moisture, excellent impact and non-impact strength, excellent resistance to chemicals, excellent resistance to cracking under stress, including when used to encapsulate components, think about teeth. Excellent resistance to abrasion, think about lateral bruxers. Low dry run coefficient of friction, which means as the mucosa is rubbing up against the nylon, it has a very low friction. Dampens noise and vibration. Think about those patients that, you know, clatter in their sleep. They clatter their upper and lower component together. They have more like a cluck, 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 cluck sound. So it dampens that sound dramatically over an acrylic appliance. Fatigue resistance with high frequency cyclical load, and you can imagine some bruxers what they put these appliances through, and of course highly processable. This is very important. You've got a material that has different characteristics depending on how thick it is. So when it has a certain thickness, it encapsulates the tooth and makes the body of the appliance. When it has a different thickness, it can be the clasp that's holding on to the tooth, right? And when it's another thickness, it's pliable enough that it can be the strap, but not stretchy. And, you know, so it depends on the thickness of the material. It has different characteristics that actually make up the different components of a sleep apnea appliance. Now, when we look at size, okay, when you compare to TAP, Herbst, and Somnament, this was done with a Narval, but you could substitute that Narval with any of the nylon appliances I showed you, and it would be very similar results. Interestingly, the density is not very different for all these appliances, but you can see the change in mass and volume. This is a patient that presented that had a ear to ear, all crowns, and he had it done overseas in one of the Arabic countries. Wasn't happy with it, so he was in the midst of deciding what he was going to do, to go back, get it replaced, or live with it. They looked like chiclets. I wasn't really thrilled about the aesthetics, and neither was he. And this is why it was a dilemma for him, although it's a lot and it's a big job to replace it all. He liked the nylon appliance, but we decided together that it would be best for him to go with a Herbst because it would be very easy to reline it in the future if he decided to change all his crowns. So he wouldn't be starting from scratch again. However, he couldn't wear it. It was too big. He came back in, I sent it back to the lab and asked him to minimize the bulk wherever possible, as much as possible. And he still couldn't wear it. He came in tears, he was so frustrated, and I basically ate the lab bill, ordered him a nylon appliance with the understanding that when he was ready to redo his dentistry, if he decided to redo his dentistry, he would need to get a new appliance, and he understood that. When we look here, we can see his Herbst, the blue one, comparing it to my sample Herbst. That was the size of his arch. When we look at his Narval compared to my sample Narval, you can see how much bigger it was. So, you know, we think about these nylon appliances as something that would be helpful for patients that have a petite, small mouth. But the other end of the spectrum also, if you've got a very big arch, a very big person with a big mouth, a big arch, you need to have a sufficient bulk around that dentition to have structural integrity. So now you're giving them this big hunk of plastic to put into their mouth, or acrylic to put in their mouth every night. And he could not tolerate wearing it. So he's been happily wearing the Narval since then. Durability, this is Luke. And, you know, this is what he did to this. This was a Somnament appliance with a flex liner. And also got a hold of the patient's Narval appliance. and he chewed the crap out of it, but got the better of it in one spot. You can see he crushed the wall. I just drilled that away and gave it to the patient. After disinfected it, put fresh straps on, he continued to wear it. The dorsal, the Sundet appliance had to go in the garbage. It was toast. There was no way any lab could restore that appliance. Now, interestingly, I don't think I have this same family. They got a different dog, so the other dog got a hold of the Norvell, this same Norvell appliance again, and it didn't kill it, right? And then about 3 months later, that second dog got a hold of it a third time and eventually put it out of its misery. So, you know, it's not like they're indestructible. They can be completely destroyed. But when you look at the chew marks all the way around on this appliance, if this was acrylic, it would have been toast the very first time the dog got a hold of it. So this is really representative of how durable these appliances are. So for female patients or patients with a small oral cavity, apparently for those with large arches as well, anterior dental work you wish to avoid, because the DSAT appliance in particular attaches and makes intimate contact with the teeth from the eye tooth distally on both sides on the top. So you can skirt the anterior teeth on the upper completely and on the bottom. So if you want to be doing future dentistry, if you want to be replacing existing dentistry, you want to be even modifying, you know, the teeth, you can let the lab know that so that they can leave you sufficient room, and it just skirts over those teeth completely. Also helpful if you're dealing with patients that have sensitive anterior teeth. Adverse to metallic appliances. Some people just don't like the idea of putting metal in their mouth, right? And of course, allergy restrictions. Now, the thing is, you have to be very careful with that particular design, the DSAT appliance, about adequate retention. Okay? You need to have very good retention at the posterior lower teeth. Otherwise, the appliance will lift off. If the patient goes to open their mouth, it'll lift off. So there's little tricks that you can do to enhance retention if it's not enough, but that's one of the first things I do when I'm evaluating dentition for a DSAT appliance is look at those posterior teeth. So before I move on to working with type 12 polyamide nylon and some of the tips and tricks, maybe I'll cover this section too, little tips and tricks, and then we can open it up to a little panel discussion and sharing some ideas, maybe some things that you've learned along the way, or ask some questions about what I reviewed here. So let me just review this part. First of all, when I first had to adjust one of the appliances, I was very concerned. Is it going to melt in my hands? Is it going to shrivel up around my burr? I didn't know what to expect. It turns out that you can use your acrylic burrs no problem to adjust this nylon. But unlike acrylic, you can remove it, but you can't add it back. So it's a one-way street. So as a result, you have to be judicious and remove in smaller increments. Okay. Polishing it, this is a material that's often used in labs, fabuluster, along with a felt little disc, and does a wonderful job at polishing. What I personally like using is these Erkadent polishing discs. Fine, medium, coarse, and it comes in an assorted pack also. And this is my favorite, the turquoise polishing disc, because it's impregnated in some white polishing paste. So the two that I typically use are the middle one here, the gray, which is the medium, and then I go to the blue to put a little buff on it. And literally, you can get it looking as nice as it did when it came from the lab after you've gone and made adjustments to it. With regards to enhancing retention, this is using a Hilliard thermoplier. So it's very similar to the process you would use to enhance retention in an Essex tray, where basically using a thermoplier to push the plastic in the Essex tray interproximally, the nylon in a DSAT appliance interproximally, or any of the other nylon appliances. So there you can see here, you may have to use a round burr to sort of thin out the appliance in that section interproximally, so that that little beak can actually get to the nylon and push it inside the appliance interproximally a bit. By the way, you'll be directed to an ebook that's a free download on my website that has pictures of all of these procedures with detailed explanation. Right now, we'll just go through it quickly. So you can download that ebook if you don't have it already. And you heat up the thermoplier, place it appropriately, and with that little beak, you're basically deforming the nylon and pushing it interproximally, enhancing the retention. And it actually works very well. Okay. Another little trick, this is courtesy of Todd Morgan from California, is these resin buttons you can place on the buccal of, say, the lower teeth where the retention is critical. Now, even if it's after the fact, you can do it before the fact and then take your impressions and they'll build it around this and take advantage of the retention you've created. But even after the fact, say you have a nylon appliance that's short of retention, you can make a little divot on the inside of the appliance, isolate, etch, prime bond, place resin on inside the appliance where the divot is, place the appliance in place, shine the curing light through the appliance, and it'll cure the resin inside. You can take the appliance off, polish it up, and you've just created all the retention you'll ever need. Another little trick is basically just heat and pinch. You can heat this two ways. You can, dip it into very warm water, although what I do is I use the flameless torch, the same one I use if I'm using a Hillier plier, and I pinch it just a little bit and either hold it in cold water in a bowl or run it under the tap. Okay, another way to enhance retention. Now, when you have an appliance made, there's very little tolerance on these appliances because they're very thin. So it's not like, you can replace a 3-unit bridge and make it a completely different shape and you're not going to be compromising the appliance. So you're going to want to be cognizant of what's existing and try and keep the dentistry as close to what's there as possible. Now, there's all sorts of different ways to do it, but sometimes a very awkward situation can come up where somebody comes in and you're not really prepared for this to have happened. So this gentleman had this appliance maybe for 3 months, right? Very new appliance. And he came in and he lost his molar, his only molar on his left, lower left quadrant. Only molar. I mean, that appliance would have just been lifted up. It needs retention there. So, of course, just taking an impression and sending it off and having to make a crown, there's no chance. What are the chances that it would actually fit properly? Now you're drilling away at the inside of the appliance and, hoping that you can actually maintain enough retention that you didn't, ruin the appliance, or the ability to be able to continue using the appliance, I should say. So what I did is I went ahead and, prepped this tooth, took an impression, and I actually took an impression of the inside of his appliance, right? Sent it to the lab and said, replicate this. And you can see they made a little template and they made a crown that fit perfectly underneath his appliance. So the day that he came in to have his crown delivered, we delivered the crown, waited for things to set. I placed the appliance in place. I didn't even have to adjust it. So when you are redoing dentistry underneath a nylon appliance, you want to try and be respectful of the fact that you've got this appliance that fits over that every night. There's some adjustment available here, but not a lot. So you want to try and replicate what was there as closely as possible to minimize any adjustments you have to do to the nylon appliance. Okay. This is a trick that will come in handy. It doesn't happen often, but sometimes this happens to be a narval, but the same thing happens with the DSAD, with the arm that goes up at the back. If it's, interfering with the patient's buccal mucosa and maybe the things are getting caught there, it's irritating them. Usually this goes away, but sometimes it's a continued complaint. So what you do is you use a flameless torch, heat it just a little bit, and just press on it. And when I say so that you can barely see it move, I mean so you can barely see it move. You just want to tweak it just a little bit and then hold it under some cold water. put it back in the mouth, and the almost imperceptible movement that you've made to it, it'll be a profound change in the mouth. They'll notice it immediately. It's amazing. And if you need to do it a second time, you can just do it some more, but you don't want to go too much, okay? And have to be going back and forth. As far as cleaning goes, any of the appliance cleaners can be used, but I find that some of them don't keep these appliances looking as white as you would like. And one of the things that's different and unique about them is they don't look medical-like. They look almost spa-like, and they're very pretty, if you will, compared to the medical devices that we've been accustomed to making. And patients, I think, like that. So I think patients are usually very interested in maintaining that nice aesthetic that they get when you deliver the appliance. This Novadent material is a company out of Quebec, and that's the material that Pantera has been recommended since they first started offering the appliance in North America. And it's one that I use routinely. The caveat I'll give you on this one is, let me just tell you that basically the appliance soaks in it all day long. Then at nighttime you take it out, rinse it, put it in their mouth, and it works great. It disinfects to the same degree all the other cleaners do, and it keeps it white. There's an issue though, and you'll need to advise your patients about this. So here we have, you can see the difference between October 20th, 2016 to June 29th, 2017, the decalcification there. So basically what happens in some patients, but not all, is a little white material builds up on the inside of the appliance. And it just blends in with the appliance. You can't even, visually you can't see it. Unless you take an actual metal instrument like an Explorer and scratch away at it, that's when it'll come off. And you can see it. Or in some other type of brush. But otherwise it's just like plastered right in there. And I don't know why it builds up in some mouths, but not in other mouths. I've spoken to the Novadent people about this. They don't know either. And all I can say is that sometimes I have patients come in with this decalcification. Each and every time that's happened, I can go to their appliance and I scratch off this film of like a white powder that's basically caked in there, right? And once this is gone, then this does not continue. The decalcification does not continue. So I make it a routine, basically, since I discovered this, to advise people, this material works great, but once a week, take your toothbrush and just brush the inside of the appliance really well, so that you don't end up having a buildup in there, which could actually affect your teeth. Okay, so that's the one caveat I'll give you on this. So before we go on to specific appliances, I think it'd be good to sort of open up the floor to talking about anything that that we were just discussing, and then we can go talk about each particular appliance at a time. We'll talk about the Pantera DSAT first, and then we'll talk about the next one. So anything you guys want to discuss about any of the procedures or any other tips that you would like to share with us, just unmute yourself and share. So it appears like I'm the only one talking, which is fine. I just want to make sure you all have an opportunity to share any thoughts or any questions about what we were just discussing. Yeah.
I just screwed up. It's David Rawson here. I turned off my camera and not my mic, and so you couldn't hear me. Anyway, I'm the first guy in the top column, so I guess you wanted to start there. First of all, thank you very much for that very good review. You and I have been both using, well, we're both using Narval and Pantera, but Narval, of course, jumped out of the market a couple years ago. You've covered it really well. The thing I like about Pantera over Narval is they offer a lot of different options in terms of what I call the anterior strap. And I tried as much as possible to have all labial teeth exposed. So I'd call it a lingual strap, so that lip confidence is more normal to what it would normally be, because most of the appliance is in the back of the mouth. Our challenge has been, and this needs to stay in this room, is that, and I work with a big lab in Ontario before it goes off to Quebec City. The challenge seems to be that there's a dental technician and a computer technician side by side in Quebec City, and very often there's a disagreement or an argument about whether or not I've got the right design, whether or not I've asked for the right retention, whether or not it's even going to work. And even though we've worked with them closely to say, whatever the doctor orders is what you need to make, regularly production has been held up because I just think they're a bit anal about what they think their requirement is for retention, which has made it a little difficult because normally you'd like to just have a working relationship where it goes the way you ask it to go. So sometimes we'll ask for what we call a lingual strap, upper and lower, and it'll come back with a labial flange, which just adds to the bulk. It makes it difficult for patients to put their lips together. It creates mouth breathing, it creates snoring, it creates bed partners upset with you all of a sudden. And I've actually cut it away when I've been able to, but that's been my challenge and my frustration with Pantera. I don't know if others have had that, but it sounds like it's a dentistry versus computer technology thing. And I know this is a brand new world we're in, 3D printed. In the old days, someone sat at a bench and waxed up a crown and made it, and it fit. So that's my feedback. Otherwise, you did a great job of reviewing the pros and cons, and I learned a few things. I found some little polishing wheels I'm going to go and buy.
Yeah.
Anyway, that's it. Thank you, John.
Thank you, David. So let me speak to some of the points that you made. First off, when there was a time period there where and I don't know if what you're talking about here jives with this time period or not. I'll just throw it out there anyway. There was a time period there where basically Pantera had to more than double their production capacity overnight. So they were scrambling trying to find bodies and train them and bring them on board. So we had relatively new people doing jobs that without years of experience behind them. This is not the official word from them. This is my take on what's happened reading between the lines, because there was a time period there where they were requesting buttons to be placed if they want us to proceed with the appliance routinely. And my position on that was, like, if you can't make the appliance without a button, then I'm going to make a different appliance. That's my personal position. Because what I found was, and what I said to them, so look at all these years, because this was post Norvell pulling out, but all those years before that, you always were able to find retention without those buttons. I mean, when the appliances that I've sent you, it was just rarely, if ever, an issue. Now, all of a sudden, every second appliance. Well, this is, once again, me reading between the lines, a technician sitting at the computer screen that's being trained, this is what you need, this is the type of retention you need, and taking the easy way out. Well, if he just puts buttons here, then it'll be so easy for me to make this and not be worried about having hit it with the retention. So we're gonna just request buttons, right? And that became more default than not, right? And so anyway, there's been some discussion about this, and I found that problem has gone away. I don't find that they're requesting the buttons like they used to. Okay, so that's one thing I just wanted to mention that I think is an event that's behind us now, because I don't find it to be a problem anymore. The other thing, though, David, speaks to what you were saying, where sometimes they will wrap the nylon over the incisal of the tooth rather than just give you the lingual. Am I understanding you correctly? What you said, basically, David? That instead of giving you a lingual, right, they would wrap it over the incisal a bit. Okay. So the reason that they would elect to do that is not because they don't want to listen to you or me or another dentist, is because they're looking at this thing on a computer screen, and they've got little algorithms that they're looking at to ensure they have enough retention. Right? And what happens when you have the lingual attachment in the front only being on the palatal or lingual only, or on the labial or buccal only, what happens is it's very flexible, that appliance, right? So the retention has to be acquired from within each quadrant. When you stiffen up that connector in the front, then the retention from this quadrant can be playing off of undercuts on this quadrant. So they have more options available to them to get better retention on the bottom. So basically, when they're saying that, well, we really need to, like stiffen up that front attachment, is because they're saying that they don't feel they're going to have adequate retention without it, right? This is different than the button. The reason I feel the way about the buttons is because my concern with the buttons is, yes, you can save the day with the button if you choose to do that. And I've explained to you how you could even do it after the fact. But if you make that routine, well, who's paying for the button? Who's going to pay for the button when it pops off? You know what I mean? And so who wants to take on that liability? I'm not going to take on that liability. I'm not going to charge the patient for it. So make it without the button, or I'll make a different appliance. And what I find is when I use that terminology, they make the appliance and it's retentive. Now, maybe it's a little bit more challenging for them to figure out where to find the retention, but they do it. So I have no concern standing my ground on that. This is different now. My position on this is, listen, if you have to even give me a full wrap, I don't care. Just make sure you have enough retention. So that's personally the way I handle that, David. If my preferences would be just on the lingual, that would be great if you can get enough retention. But if you actually need to get more retention by wrapping it around the incisals, then I accept that because I know it's because they need to have more retention. Now, obviously, it requires some faith that they're actually doing it because they need to do it, not just to get the easy road out. And we'll never know which of those two it is, So I think maybe that speaks to that issue that you were talking about. Any other thoughts or comments? So let's talk about the DSAD then. I'll show you a few slides on that, and then we can. So the actual biting surface, the plateau, they like to call it. You can have it touching only on the sides. You can have it touching horseshoe all the way around, or you could have it touching only in anterior. And in the anterior, you can actually define that it will go from eye tooth to eye tooth, or lateral to lateral, or just over the incisors, the centrals, so that you can define how anteriorly you're touching. Okay. So obviously, the anterior only is the anterior midpoint of student stop concept, right? And the straps, basically, you can have even if you custom option something, they can do it for you. But you can see you can have a simple buckle, simple lingual, and the 3/4 strap is where it just wraps over, the incisal edge. Okay. Last year in April, they introduced their new straps, the RODS 2.0. And they did a whole bunch of research because they used to have different types of straps. So standard strap, little B strap for bruxers, capital B strap for heavy bruxers, right? And they came up with this based on their research, and they feel that it can manage 99% of bruxers. You can't even order their thicker straps, which is the RODS Plus strap. They want to make that decision if you need a RODS Plus strap after they look at the design of the appliance and the situation. I've had one patient actually break these 2.0 straps, and I had to move on to a RODS Plus strap for one patient since these became available in April. Whereas before that, I could honestly say that I would have to move on to Brux straps much more often than that. Okay. So far, it seems to have been a good enhancement and definitely taking care. I don't know if it's going to turn out to be 99%, but this is what their research has shown. And I'm sure that you've all been exposed to the V tabs, vertical tabs. They can be ordered through the dental lab, made out of California, and basically there's different colors, clear, white, or blue, 1, 2, and 3 millimeter thickness, and you can actually increase the vertical. And they can actually be stacked so that you can increase it to different, like 5 mils if you want, by stacking a 2 and a 3, for instance. Yeah. Any questions about the DSAD before we actually move on to the X3, which is a brand new appliance? Anything that experiences you've had that you want to share, or anything you'd like to talk about or ask questions on? Yep, David?
Hey, John, so I just thought I'd circle back, and again, I never want to leave anybody with the impression that my way is the highway, but I think what we've both agreed on is that this is the first time I've been around the block a little while. I've been a dentist for over 40 years, and we worked with people who make things by hand, and you can all think back to whatever kind of dentistry you did, you kind of knew what kind of dent you're going to get because you worked with your lab technician. You never had to adjust things. It always worked, and whatever you wanted to make, they generally provided. We've now stepped into the digital world, and this is becoming corporatized. It's becoming automated, and everything we've talked about in terms of your problems and my problems has been, I think, the fight between lab technicians in Quebec City and computer technicians. And I actually work closely with a technician in London, RDT, who pulls his hair out by the handful, because even when he talks to that Quebec City, they just don't get that we're totally okay with what we've asked for. So that has been a learning curve for everybody. But when you take the human away and make a machine, you lose a lot of that finesse that we humans understand. A final point about your buttons, and I agree 100% with it. And one of the questions I had through my lab and through our salesperson, whose name shall go unmentioned, how the heck do they know which teeth are, well, the teeth they choose for buttons, how do they know they're not gold crowns, ceramic, amalgam? How do they even know it's going to bond? Because we just send them models, so I don't send any photographs. And they've chosen teeth for me to put buttons on that would never even work. And I understand, John, whose job is it to put it on? We'll put it on. Who pays for it? We absorb the cost when it falls off. I get all that. I just think we need to understand that computers, as smart as they are in dentistry, can't replace the experienced thinking person who's been doing it at the bench forever. And we dentists just don't get that part. So that's the end of my rant. I just wanted to kind of put that together in terms of why computers aren't necessarily the best thing for our profession all the time. Thank you.
Appreciate your comments, David. They have somebody sitting in front of a computer screen very similar to what you guys are doing right now. And they're looking at a file of the teeth, and they're designing the computer, on the computer, the appliance, the position of that bar, where the strap is going to connect to, where the connectors are going to be here. And on that screen, there's different colors that show the level of retention. It actually shows up on their screen. So if there's too much retention, they have to block it out. And if there's not enough retention, they say, geez, we can't make the appliance on this set of teeth. So they have to try and find a way to make retention. The easiest way, which is I think was happening for a while there, especially with inexperienced people up front, they were saying, well, we'll just put buttons here. I think they've gone away from that now. The other way, which has always been the case since 2011, 12, when this was first being created, was basically the option of a strap that's more rigid in the front, because they can then play off the retention off each other. So it's a step thing. I think they're trying their best to give us what we ask for, and most certainly, if you're actually writing your prescription, do not alter prescription without contacting me first, then they, will do that. There's no reason for them not to do that. Okay. So any other thoughts on the DSAD appliance before we move on to the next appliance? So the X3, something brand new. As you can see, it's a dorsal style appliance. right? So similar to the Sonident that we're all familiar with, right? And you can take you look at this picture here, you can see the upper component, the stop it's resting up against, that the dorsal fin is resting up against. You can see there's like, it looks like something that's like, slid into the slot there. And that's in fact, what's happening here. Sorry for the pictures being a little bit light, but this is all I can get on this device. There's just no materials available, promo materials available. But you can see there's different components that go in like a Lego set, right? That advance the jaw. There's 3 different angle options that are going to be available, similar to the Micro 2, so a 90-degree angle. Similar to the Snore of years back, where it's an angle that doesn't allow the jaw to drop open, right? Because it's negative 20 degrees. And then similar to the angle of the standard dorsal appliance, about plus 20 degrees. So you can, when you're ordering your appliance, you can decide which one of these you want to use. My caution, of course, on the Snore is because it literally locks the patient in place, does not allow them to drop open. You really need to have very, very, very solid retention. Otherwise, they'll pull out of it. It'll pop off their teeth. The Micro 2 90-degree angle would be more prone to that than the standard, because the standard angle, basically when the jaw drops open, it just comes apart, right? There's no torque on anything. The lower component stays on the lower teeth, the upper component stays on the upper teeth. Whereas when you're at 90 degrees and you're coming down, there's some friction and you're dragging against that because jaw wants to come back. So if there's not sufficient retention, it could pop off. That typically would be the lower. Same thing applies to the Prosomnus 90-degree angle IA, for instance. You need to have very good retention, otherwise it can pop off if it's not good retention. So the most forgiving retention-wise here would be the standard dorsal. But then the caveat there is that if you put elastics on this thing, stop the jaw from dropping open, if there's not good retention, it'll pop off, just like it does on a dorsal appliance now, made out of acrylic. These are some pictures that perhaps show you a little bit more detail. I was able to capture these at a conference a few months ago. I don't have the appliance in my possession, but I was able to snap some pictures so I could show you the components and what it looks like. So before we move on to the next appliance, any questions or any thoughts about this particular design? Any thoughts about having the 3 different types of angles available to you? Is it something any of you think you would see utilizing? Because what they're trying to do here basically is make like 3 appliances in one. That's where the name X3 comes from.
I hate to be the only one speaking, John, but you and I do this full time, so maybe it's easier for us to jump in. This kind of reminds me of the SomnoMed, I think they call it deflection or whatever. Some of our patients are elderly, their eyesight isn't great, their hand-eye coordination isn't great. The more Lego pieces you bring into this system, the more confusing it gets for everybody. I'm very impressed with I think they call it the Avant, a very simple appliance with a blue strap on it. I've got about 15 in use now. Of course, we're shut down, so nothing's getting done. But I think too many parts confuse everybody. I want to make it simple, and that's why the Phonetic Bite, I think, 3-dimensionally gives you the best starting position, and the fewer parts and the fewer titrations you need to do, the better you're going to be. But that's my point. That's where I'm coming from. Thank you.
I'm not, I don't know that I would be giving the patient these components. When this appliance comes to market, I start making some of them, I would be holding these advancement components back, like I basically keep the advancement straps for the DSAD in a kit, right? I have a generic kit, and then I just, advance. So, I mean, there's some appliances that are more amenable to advancing at home, like home titration, and other appliances that I think I would prefer to, make that change myself. And so I do both at-home titration and in-office titration. And that's one of the considerations I make when I'm deciding which appliance a patient is going to get. And, I haven't decided for this one yet, but I'm pretty sure right now, the way I feel anyway, is that I would be keeping these components and doing it in-office titration rather than letting them fumble around with it, But I mean, I have never even handled one of these yet to actually change the component out to see how tricky it is. So I can't even speak on that. That's how new this thing is, right? Just before this whole pandemic thing started, I sent my scans away, and I was supposed to get a copy of each of these 3 designs to actually try out in my mouth and comment on and so forth. And I mean, they got my scan, but then this whole thing started. So I don't know when I'm going to see these things to try them out. I was very much looking forward to that. And at some point they'll get back into production, and I'll get them, and then we'll go, and then there'll be the discussion about when this comes to market. I imagine that the earliest would be the fall now, considering, I mean, there's so many unknowns with regards to any timing for any business decisions for any company right now. We don't even know when we're going to be 100% back into our offices, right? So the Aventus O2 Vent Optima. I'm sorry, did somebody want to say something on? No? Okay. So the Aventus O2 Vent Optima. Breathing channel. So notice the same thing, polyamide nylon type 12. This has got EMA-like straps. So unlike the DSAD appliance where it's traction, but it's horizontal, it's along the horizontal plane, pulling straight forward. This is EMA, traction obliquely upward and forward, okay? So when I say EMA-like, okay? They actually have their own proprietary straps that they had to develop in order to bring this to market in the US, because Meyerson would not let them use the EMA straps in the US market. We can use them in the Canadian market, but not in the US market. So, I need a little more of this. So you see the appliance in place, then you think, my gosh, an oral breathing channel. I mean, is that really good? I mean, do we want to promote mouth breathing? I thought it was all about nose breathing. Everything we've read, everything we've seen is about nose breathing, okay? Well, what I can tell you is this. There is evidence in the literature that when the palatal collapse, the collapse happens at various levels along the airway in every patient, okay? But when the palatal collapses predominantly at the soft palate area, oral appliances don't fare very well. When it collapses mostly behind the tongue, the appliances actually fare very well because we have a lot of impact on that part of the airway. The whole idea here of the oral breathing channel is when you have palatal collapse, right, you can still breathe. So the oral breathing channel is facilitating breathing when the airways collapsed higher up. So it's not meant to replace nasal breathing. It's meant to aid and facilitate mouth breathing when the airways collapsed higher up the chain, okay? Now, the thing that makes it interesting is this PEEP valve. And what it is positive end expiratory pressure is PEEP. You place it in that little channel in the front, and when you inhale, the little sleeve inside allows normal airflow, but when you go to exhale from your mouth, it closes up and it restricts the airflow going out, so it creates a positive airway pressure, helping to reduce collapsibility of the airway. So it's the whole PEEP concept, whether it's nasal or oral, it's the same thing, but it's an oral PEEP valve. We've known about the nasal PEEP valves for years, and this is an oral PEEP valve. This is available. They have a 1 PAP valve that is currently in development. Same thing, it slides onto the front of the appliance, and it has a nasal component to it and an oral component as far as breathing, and it's calibratable. So it's not just, the PEEP valve comes in 3 different strengths, light, medium, and strong. Here it's calibratable over a range. So you can calibrate the amount of resistance to breathing out based on the patient's needs, right? And this to me is very exciting because that really helps, like, doesn't matter which way you're breathing, from your nose and through your mouth, you know, it helps to maintain that positive pressure in the airway and preventing the airway from collapsing, okay? The next level of help would be, of course, an attachment to some positive airway pressure. And this is something else that's in development. It's being staged. First, the Optima was introduced. The PEEP valve was introduced. The next component that will be introduced will be the 1 PAP once it's ready for market. And then the final component will be the attachment to PAP. And so what they've done is created, basically, this is first choice. What you go is this: if you don't hit it and you're not getting rid of all the apnea, you can add PEEP valves. If that doesn't do the job, you can actually add the 1 PAP. And if that doesn't do the job, now you can, you know, marry it up and do combination therapy with PAP at the same time. And it's the same base appliance that's allowing you to go through these stages. Thoughts? How do people feel about the oral breathing thing? Is that a concern at all?
Does it bring that much to the table?
You don't think it brings much to the table? I'm sorry, who was that?
I'm asking, do you think it does?
Oh, you're asking me. Well, I'll tell you, the oral breathing part of it, I'm, you know, the jury's out for me. I'm not sure. I'm just explaining the concept of why it's being developed. The PEEP valve part of it, I think that has the potential to add value, especially not so much this oral PEEP, but the nasal, the 1 PAP, you know, which is in development right now. Last time I had a conversation with Chris Hart about this. Their issue that they're trying to work out right now is that the nasal interface. Okay, it's easy, you know, you slide it onto the appliance, you know, that's nice, simple. But how do you make something so that it'll stay in place and it'll fit everybody, right? If it's going to be an over-the-counter thing. And so they're playing with digital imaging, and, you know, they're trying to come up with a troubleshoot that. That's the last I spoke to them, was like maybe 5 months ago on that. I don't know how far along they are. And of course, this COVID thing has probably slowed everything down, all development and everything, because that requires funding. And this is, you know, who knows when that's going to come to market. But I think that potentially it could be really cool. You know, and it's once again the positive end expiratory pressure part of it that is interesting to me. As a matter of fact, when I first saw this design, I didn't really make much of it. I was very concerned about the oral component of it, thinking that this is more of a detriment than a positive. And it wasn't until that I was shown this PEEP component that they got my interest. I thought, oh, no, this changes things completely now, because it actually changes it to a different animal altogether. Now, the jury's still out. I mean, there's been publications on this, and, you know, they're showing good results, but it's not like they're showing, oh, well, we can treat everybody. No, this is why the stepwise fashion here, where if this doesn't work, you have this option, you go to this, or you go to this, but it's not all on the table to use yet, right? This is just all a dream right now. You know, the first 2 are there, but the 3rd one and the 4th is just a vision in someone's pupil of someone's eye right now, you know, until it's on the market. And I think we all know the difficulties and the obstacles to bringing things to market. So even if something's being talked about, this 1 PAP might not be available for 2 years. Who knows? You know, I mean, I have no idea. So I'm sorry, who asked that question?
You did.
Oh, no, did it bring anything to the table? Or who is that?
Smart.
Mark. So, Mark, what do you think? Based on everything you've just heard, do you think it brings anything to the table? I'm curious. I'm curious what other people think about this.
I really tend to block these type of appliances out. I never had good success with anything nylon, number one. But number two, well, you know, these are hinged. In the States, if you do Medicare, I'm sure most of you know this, and most of the major insurance carriers are starting to follow the Medicare guidelines, which eliminates any appliance that is not hinged.
Interesting. I'm so glad you brought that up, Mark. Okay. So this, of course, people that from the States that are working with Medicare probably have very little use for the nylon appliances for the reasons you just said. I get that. You know, I work in an environment where most people are paying out of pocket. And so, yeah, I'll take that small one there, that really light one. Yeah, I like that one. You know, that plays more of a role. Now, what you need to know, Mark, in the last few months, I can't remember exactly what month it was. In the last 2-3 months, you know, I post something basically talking about the Optima getting their PDAC number. So it's Medicare approved. Now, of course, you know, its price point makes it so that you really couldn't use it for Medicare, but where that helps is for insurance companies that won't accept an appliance unless it is PDAC approved, it does qualify for that now. So in that particular case, when you have third-party coverage that uses that criteria, the Optima will be a candidate for coverage now, whereas a few months ago it wasn't.
Yeah.
And that's new information, as just of the last few months.
Yeah, you were the one that brought up expense. For
I'm
the
sorry?
most part, Medicare supplements significantly increase the reimbursements. So that's sort of not my issue anymore with Medicare patients. It's whatever the
Well, I
appliance.
mean, so, okay, the Medicare supplements, you mean through Medicare? I have no personal experience with this, not having to deal with it. You can even use the more expensive appliances through Medicare now? Oh,
Not true.
how recent is that?
I learned about it about 1.5 years ago. It's not through
Oh.
Medicare. You know, Medicare in the States pays 80% for the most part.
Right.
So most people carry a supplementary policy, and it's the supplementary policies that reimburse fairly well.
Right.
So usually, yeah, it all averages out about the same, commercial versus Medicare at this point.
It's interesting to know. I'll have to have some more conversation with you about that because I want to understand it better. Only when I'm speaking to dentists from the States so that I better understand what their environment is, right? Okay, so any other questions about, yes, sir?
I haven't followed Oventus for quite some time, but I think before they actually had approval to be here in the States, they had a prototype that had a metal component to it. It had some titanium in it and kind of a smaller tap type hook that hooked them together, and also with a PAP component. My question to you then, did they get to the point where they had an appliance where they've had the ability to utilize the PAP component? Maybe not the nasal pillows, because I think the original was just through the vent.
Okay.
Were they successful with that, or did that ever make a market?
Okay, so I'll tell you what I know. I mean, prior to them going nylon, right? And they started, I made the first 5 in Canada in February this past year. And then by the summer sometime, they were actually FDA cleared to go into the States. But prior to that, my exposure to their products was titanium, and there was actually the tap-like version and a dorsal-like version.
Yes.
And there was a monoblock type version. It was 3 versions out of the titanium. They may have been talking about having a CPAP attachment, but I highly doubt they ever actually had a CPAP attachment, because if they did, they would have it available for now, because it's the same connector in the front. that they have on those other titanium appliances. So, and even if it meant modifying that adapter in the front, right, for the nylon, they would still have it, you know. So I have not seen in any of their literature that they actually had a PAP component available for the titanium versions of the appliances. This is something that's on the to-do list going forward.
Yeah, that's exactly why I asked that question, because I would have thought that had they been successful with that, this would be a short step
Right,
to
right.
where they're
There
at
should have
now.
been something right out of the gate. They should have been offering that.
Yeah,
And that's why I have not seen it in any of the literature I've received from them or any of the documentation I've received from them. So I doubt very much that they had a component, an attachment component in play, you know, with the stainless steel. Yeah. Or titanium, I should say, titanium. Yeah.
Okay.
Matter of fact, you know, when it was, you know, the thing that sort of caught my interest here, honestly, is the PEEP valve. I dismissed it completely, personally, when it was just the oral channel with their original versions. I didn't understand the concept about promoting oral breathing when we know that nasal breathing is so important. And it wasn't until they came up with the PEEP valve and they told me about that, I said, wait a second, this just changes the game. I don't know how much it changes the game. It's still, you know, early in the game, right? And I don't know how much the one PAP is going to change the game when it comes to market. But at least it's an interesting concept that, you know, may make the difference. It might kick things up a notch or 2 notches or 3 notches from a certain level of success to that much more for certain patients. And I think what we all will agree on is that, you know, just having these different tools available, right, helps us increase, you know, it's just not just about making an appliance and putting it in. You know, it's about understanding the use of positional therapy and other adjunctive therapies, understanding how to speak to the patient about different things like the importance of weight loss, and not only positional therapy, but head position, neck position when you're speaking and so forth. All of these things help us to up our game. And so the more tools that we have available to us, right, the better. So that's why I'm always interested. Oh, maybe this will make a difference for some patients. And if somebody's got compromised nasal breathing to begin with, and we've all had those in our practice, where they come in and they go to the ENT and they have procedures done and this and that, and they still can't breathe for shit through their nose. And they try, but you know, they could, and so now you're dealing with somebody that is breathing through their mouth no matter what. Right? Well, maybe making one of these with a PEEP valve or a one PAP valve would be the ideal appliance for that particular situation, as opposed to making another kind that, you know, well, wishful thinking they're going to breathe through their nose. That's what we really want them to do. If they're not going to be breathing through their nose, no matter what, right? It's just you know, things to think about here. I'm not saying it's the answer, but you know, I'm thinking that, you know, maybe, you know, for a certain phenotype of patient, this might be a good appliance to consider.
I remember,
especially with the PEEP valve component. Yeah. Sorry?
I remember when they the prototype, they were thinking that the price point on that would be something around $700 US for the titanium style appliance. I don't know what they ever got to market with, but what are these appliances here, like the one with the PEEP on it? Do you have any idea?
Okay, so the PEEP is a little separate gasket, if you will, that is, has a lifespan, and then you throw it away and you put a fresh one on, right?
Yeah, yeah.
But a base appliance here in Canada is 6 and change. I don't know, 640, 650, something in that range there. So it's in the same type of price range as the DSAD, in the same type of price range as the Avant. The new Avant appliance, approximately. So it's the higher end pricing.
Well, thank you very much. I appreciate your input.
Yeah. Okay. So no more questions on that, and we can move on to okay, DDSO. You know, Diamond Digital Sleep Orthotic. I don't have any personal experience with this at all. Basically, because you know, they want to offer it in the States, they have to make their own proprietary straps, which you can see pictured here. On the previous appliance, you saw that original Emma straps that were pictured on that Oventus appliance. These are the DDSO folks, their straps. So made out of sanaprine, so it's a little bit stiffer, if you will, than and less of a chance to stretch out. Although I don't have any personal experience with sanaprine, so I don't know how long they last before they stretch out. I know what happens with an EMA strap, and we all know what happens with an EMA strap. So the sanaprine supposedly deals with that better, but then again, you don't have the different durometers, you know, for certain patients that comes in handy. You can see here lingual buttons. So this concept was taken from the work that Mark Abramson has done on his Oasis appliance, and as a tongue trainer to, you know, train the tongue to come up and forward and stay out of the airway. Okay. Then he's got little tabs that actually clip on, right, with vertical adjustments, so that you can change the vertical with these little snap-on components. Okay. And then they have a connector for a PAP available, okay, for a pillow mask. That's really, you know, I can share with you about. I know it's available in Canada and the States. I can't, you know, obviously it's an EMA strap design, oblique traction pulling upward and forward, but you know, I mean, he's got these nice features that basically have been borrowed from different appliances, and so it seems to be well thought out. It's the one that comes with a 5-year warranty, and even if you lose it, you know, they'll get a replacement, but it's $100, and I believe that can be exercised one time. So, any thoughts? Any comments? Any experience with it? Has anybody made a DDSO? Any thoughts, Mark?
Yeah, again, I've never had great success with nylon, and I don't like the EMA straps.
Right. So the EMA straps, I agree 100% on. You know, they just stretch out too quickly, and it's so varied from patient to patient, and you never really know where that patient is. And they may feel that they're optimally being managed, but meanwhile their strap is stretched out and they're not optimally being managed. So it's really like too loosey-goosey. So supposedly these new sanaprine straps are better that way, but without any personal experience, I have no way to verify that. You know, and the nylon, Mark, what I can tell you is, anyway, I'm just off the top of my head, I think it's about 40% of the appliances I make are nylon, you know, and I've had, you know, very, very satisfied patients, you know, with them. So, so I'm very much a fan, and so I have no problem with somebody saying, no, I prefer not nylon, but I think there's a lot of good attributes to them. You know,
I haven't made any since I went digital. You know, after 30 some years of taking impressions, maybe I didn't know what I was doing back then. But yeah, maybe I should look at it again. But again, it's the straps.
Let me tell you something, Mark. It's really important based on what you just said right now. I just recently obtained the digital intraoral scanner. It's been the last year. So up until then, not only was I not taking digital scans, all of my appliances were being made from alginate impressions. Alginate, not polyvinyl, right? The alginate's taken, Elaine walks right in the other room, pours it up immediately. Okay, and we've had great fitting appliances. We don't have an issue with retention and so forth. So this, you know, this notion about, you know, what's needed, a well-taken alginate, poured up immediately, and good quality stone is all you need. I can tell you from years, that's all you need. So you don't need to be using intraoral scanners to be making nylon appliances, you know.
I just had no luck.
Yeah. Yeah. Okay. So
David
anything
here.
else?
Could we ask Mark what? Yeah, I just wanted to ask Mark what his problem was with nylon, what his experiences were.
Yeah.
I think I just didn't do enough of them to feel comfortable with retention, with changes in restorative dentistry if something was to change. I wasn't good at modifying the appliance. Again, the straps. Yeah, I like something that's metal that I can calibrate. I'm looking over there. You're over there now. Something that I can calibrate.
Yeah, I'm over here.
Yeah.
Okay, that's all good.
Yeah, and those are all very legitimate concerns. I tell you, Mark, when Resmed first came to me and showed me their appliance, I told you, like, I laughed. I mean, I didn't take it seriously for a while. But then, I started dabbling with it, and I realized, well, hell, we're not getting any advice or guidance at all from these companies. They're just throwing this appliance at us, and we don't even know what the fuck to do with it. How do we adjust it? How do we deal with dentistry underneath it and so forth? And that's where that ebook, came out. When it first came out, I think 2014, and it's been updated 2-3 times since then. The most recent update was last year. I'll be doing another one this fall. So if you haven't downloaded it, just go to my website. You can download it free, and just take a look through it, because in there it basically talks about all of the issues that you brought up. And the idea is to sort of like have people feel comfortable with these concepts, because I can absolutely understand where, geez, I don't want to get involved in something where what if I have to change somebody's restoration here? Now I have that liability hanging over my head. Look, I'm the guy that doesn't want to place buttons because I don't want that liability hanging over my head. So I absolutely get why that would be a hesitancy factor. So and that's why the ebook was put out there, is to help sort of alleviate some of that concern and distress. Yeah.
I'll go back and look at it again.
So this is something new, something brand new, and it's once again from the Pentair people. Now it's actually soft launched in Toronto here, so it's available in Canada through the Dental Services Group lab, and I imagine will be eventually available through the States, and probably any other labs that are working Pentair will also have access to it, but I know Dental Services Group definitely does, because they have access to it up here in Canada. But it's one of those things that is probably going to be impacted upon by this COVID thing, timing-wise also, right? So any of you have any idea what I'm about to show you? Any ideas? Okay. This is a Brux appliance made out of the same material. Okay, upper with occlusal anatomy, lower with occlusal anatomy, upper and lower, and you can see how there's no contact distal to the molars, well, the distal to the sixes, I should say, or the first molar. And you can have middle and lower contact. So here you have anterior contact, and then you have from first molar to first molar contact, a full horseshoe all the way around. But there's no contact distal to that. So I'm going to show you another view. Okay, so that shows you the milled occlusion. So when you order a grinding appliance for somebody right now, just think about when your Brux appliance, and then you're basically checking the bite and balancing things and everything. Most often that's done chair side. Well, here with accurate impressions and a bite registration, it'll be milled in so that the bite matches perfectly. You may need to adjust things a bit. I don't know. It depends on how accurately you do your bite registration and so forth. But theoretically, it should be as well fitting as any steep appliance you put in. I need to take it back a slide because I wanted to show you here how, see, there's no distal contact. If it was just anterior, it would be from cuspid to cuspid. And I'm sure that if for those of you that want to make it a tighter, just contact over the incisors, the centrals, I'm sure that they could do that. But the two basic designs right now are cuspid to cuspid, or first molar, middle of first molar to middle of first molar on the other side. Okay, so taking away any posterior contact at all put together. So obviously the lab bill on these is more than the acrylic lab bills, but it'll last a long time. So when you have those Brux patients that really chew through their appliances so quickly, which is not really a good practice builder, right? This would definitely be something that's a consideration. because it would be, put it this way, knowing the experience I've had with nylon and knowing how well it stands up to what dogs do to it when they get a hold of it, I doubt very much the human is going to be able to grind through these appliances. I don't know how long they're going to last, but they're going to last a long, long time. So thoughts on this?
They're basically grinding appliances and not repositioning appliances.
Right. That's nothing to do with sleep apnea. This is a Brux appliance. Yeah.
You keep things balanced properly, you might minimize bruxing.
Yeah. So basically, whatever way you normally use a Brux appliance in your practice, right? These are the different versions of it. The beauty here is that, because you've all got different backgrounds and different training and different preferences, you're going to probably want different designs, and they'll be able to accommodate, anything you throw their way. Now that they are on this platform where they're actually using this material in this way for this style of appliance. These are just the base designs that they are introducing right off the bat. Then after that, it's going to be people that, give them feedback. I showed this to Isaac Barzilay in Toronto, is, top clinician educator in implants. And I showed it to him, and he was very, very pleased with what he saw. When somebody's doing a full mouth reconstruction and putting implants, everything, we know that you're going to put something in there to protect their teeth if they're not wearing a sleep apnea appliance, right? And so you want to be protecting that level of investment very well. And this I think would be the ideal type of appliance, especially if you're sort of restored everything and you're good. Now you want to preserve it and protect it. So this is getting away from sleep for a second and just talking about that type of need. Any thoughts?
Pretty basic.
Yeah.
It's
Under the auto, Canadian.
It's
Okay,
an
so
obvious extension of their new technology, John.
I'm sorry?
I say it's an obvious extension of the new technology. Now they can make anything in nylon that we've been making in plastic. So who's surprised?
Yeah. So this is the ebook that I was referring to. If you don't have a copy of it, just and you're interested in getting a little bit more into the nylon appliances, then I'm an email away. I mean, it's not an issue. So, I mean, this was really today's topic that's on the books. Next, if I'm not mistaken, I mean, next week is oral appliance selection. Like matching patients, and we'll be talking about that. But for today, it's 4:25. I mean, is there anything that comes out of today's discussion that you guys want to throw around, or is there any other burning questions you might have about even something else? And if not, then I'll bring something up.
John, sorry, we have
John, I'd like to just.
something.
What's that? Okay, let's hear Dave first, Elaine. Yes,
sorry, from Alexander Mayer, we have a 2019 German SV guidelines. Brooks is approved in nearly 40% of all Bruxing persons, and SRDD/OSA. So those heavy Bruxers should be sent to sleep lab first.
Right. So I think we all know that the association between bruxing and putting an appliance in and having their apnea get worse if they have the existing apnea, and this additional information that Alexander shared with us. So that's on a different level. We know that this is just basically a new appliance that Pantera's made available for us. So I'm sorry, David. You were going to say something?
I just want to circle back and can you hear me okay?
Yeah.
Okay, I just want to circle back and pick up a conversation that Mark was having about his, I guess, dissatisfaction with nylon. And this all kind of fits to everything we're talking about today in terms of old technology, new technology. Joan and I are both in Ontario, about 2 hours away. We're high volume users, and we were both approached by Brad Showbrook from ResMed when they first launched. My reaction to Brad was a little more, I'm not sure if this is going to work for me because I do a lot of vertical, as you probably saw if you were at the talk a couple weeks ago with my vertical bite registration. And he scratched his head and said, "Oh, no, we can't do that." And I said, "Well, I can't work with you. If you can't add to this material and you can't make it thick enough, we don't have a deal." They came back and said they figured out how to do it. So Mark, the most important thing to know about nylon, as I'm sure you know already, you just can't add to this thing. All you can do is remove it. Everything else we make in dentistry, we can reline, we can rebuild, we can put new teeth in, we can change all kinds of stuff down the street in a day or two. So for me, I like nylon because it has a lot of advantages, but I build it to the maximum, knowing that anything I do is going to be reduced height, reduced flange. I can polish it in the office like John showed you, and it really does work quite well. Patients love it, especially females who have a small mouth. It's so smooth. It's something new. I think everyone's kind of excited about the newest thing, the newest gadget. But I would strongly suggest, and all I've ever done, and John, I think, spoke to that as well, I've only taken alginate impressions. I use ChromaPen 100 hour. I insist that it's poured up in the lab before the end of the day, so they're all fresh impressions, good bulk, great retention, no high technology. Nylon works. It's quite successful. I'd be happy to help you in any way you can, but I think you need to get back on that horse and ride it some more. Thank you.
All right. Thank you.
Are there any questions there, Elaine, in the chat box? No? I think we've been basically addressing them as we go. So I'm gonna, if there isn't any questions, I'm just gonna throw something out there that John spoke yesterday on the matrix again. And one of the things that he brought up was, this PAP being associated with spreading this COVID-19 in the nursing homes, and it's implicated as one of the problems that helped to create the whole ground zero in Kirkland there in Seattle. And one of the things that I asked him about, and he actually, agreed with, and was that with PAP, forget about the fact that you've got filters, and yes, it's not a closed system like a ventilator is. So you're obviously going to be exposing the room. We got Tiger has just published something this month on some components that he's put together to basically put a better filtration system on. Now it could be used on some machines, but because the home machines are made all different styles by different vendors, it's not something that's going to be easily retrofit right across the board. So most of the PAP machines out there doesn't really apply to. But even with these efforts of making them maybe more of a closed system, it'll never be a completely closed system, but more of a closed system, there's still the issue of the face mask. And if you got a mask, you're going to have leakage. And even ResMed, when they talk about a mask fitting properly, they never say, their position is never that you should make it so there's zero leakage, because they know it's virtually impossible, right? So they talk in terms of an acceptable level of leakage, right? So what is that? It's amount of leakage that's not going to impact negatively on the therapeutic benefit that the PAP is giving the patient. But, and the question I threw out to John yesterday was, is there any level of face mask leakage that's acceptable when there's a contagious virus going around? And of course, we all know the answer to that is no, right? So irrespective of putting extra filters on and additional components and this and that, the system, the whole PAP system is flawed and cannot be used safely in a household or in an institution, right? Because that face mask interface. Okay, the jaw drop, he mentioned yesterday, mouth drops open, air's coming up for the patient's mouth. But even if you're using a full face mask and you get rid of that problem, you still can never be guaranteed that you won't have face mask leak on some level. So unless you can make it a closed system, right, you're going to be sending that contagion through the air and exposing the other people in the room and in the household and so forth. Now, did anybody on this blog or anybody that even think about this before COVID-19? I know I never did. But now, in this current world, now that we know that that liability is associated with wearing PAP, we can never unknow that. It's there, it's in our head.
But John?
And whether it's COVID-19 or any other flu or any other virus or anything, because COVID-19 is not the first contagious virus and not the last contagious virus. Now compare that. I'm just going to say, I'm going to finish in a second. Compare that to the oral appliance alternative, which does not blow this stuff around the room and throughout the household, number one. And number two, is very easy to disinfect daily. Throw it into a solution and you put it back in, as opposed to the hose, mask, and machine, right? That, disinfecting is an ordeal, right? And especially when you're dealing with a contagious situation. So I just wanted to throw those thoughts out there.
John?
Yeah.
Let me be the devil's advocate. The PAP is only spewing out what's already in the system, and anyone in the room who's breathing is doing the exact same thing, just at a lower velocity.
Yeah, well, I think the difference of velocity is more than it's not as benign as one thinks, right? It's positive airway pressure, it's positive, you're sending it out projectile fashion, so.
By the end of the night, a bed partner is going to have it either way.
Right.
Yeah,
and so if you take the position, well, you're all fucked anyway, well, then that's fine. You know what I mean? But honestly, I think this is a concern. I think.
You got a lane to smile.
I think, John, I listened to John Rummers yesterday, and my immediate response is, I think we as dentists need to be careful about the appearance of trying to find everything negative we can. I know that's not what you're doing, John. Bear with me.
I know.
Negative about about CPAP and force the alternative into oral appliance therapy. And dentists have been doing that for years. So we are labeled and expected to do that, and it's not to our advantage. I think that what surprised me the most was his statement that the sleep American Academy of Sleep Medicine's standard now is that it should not be given prescribed in this point of time.
To somebody that's COVID positive, yeah.
That's not what he said.
That's what I heard.
That's okay. Maybe that's
my understanding too. I might be wrong, but
let's
my
keep,
understanding. Yeah.
And you can understand when we're looking at the studies out of Southern California, whether they're valid or not at this point, I think they may be a little exaggerated, but they certainly are. I think we're about to find that their estimation of asymptomatic positives is in the neighborhood of 40%. So is it going to wind up being 40%? The answer is probably not. Is it going to be higher than 30%? The answer is probably so. So with that in mind, does CPAP have a potential problem in the future? Unless they create a closed system, it might. But here's my question. that was his statement. Now we got to find out what exactly. Go back and see what it was. I thought he was saying it was inappropriate to prescribe it at all at this point in time. Which
I'm going to look it up, Barry. I'm 99.9% sure for, for COVID positive patients, but I'll look it up while you talk.
No, I'm done talking. You know, I've already.
Yeah, because I have it in an article here that I penned, and
but it blew me.
So you guys keep talking. I'll look it up.
I almost fell out of my chair when he said that. Because now you know we are talking about someone who is very oral appliance oriented. But nevertheless, that really surprised me. And I'd love to find out exactly what that position is. But the answer is I don't know about anybody else. I never thought about it. I mean,
neither did I. American Academy of Sleep Medicine currently recommends that if a PAP user becomes positive for COVID-19, they should speak to the physician about assessing risks and benefits of continuing to use the PAP device at home.
Gotcha.
Right? So that's the official ASM position. Not that you should stop using it. Speak to your physician. And weigh out the risks and benefits. Maybe if you've mild sleep apnea, Barry, you know what I mean? Okay, you know what? Maybe but look at your cardiovascular risk here. This is your history. You got like 79 events per hour. You should sleep in another room, isolate yourself, and use it. So I'm thinking the conversations would go something like that.
John, we have one question from Alexander.
Yes.
One question comes up in my mind. In Germany, only existing nylon oral appliance on the market is the DSMS Narval. There was a long discussion about how to bring face bell into the workflow. Does any of the nylon
how to do what into the workflow?
Face bow into the face bow.
Face bow?
Face bow. BOW. Face bow.
Face bow.
Face bow to just arbitrary.
Face bow.
Face bow.
For changing vertical dimension. If you want to change vertical dimension, you have to use the face bow.
You have to use the face bow to change vertical dimension?
You should, yeah.
Why?
To bring the oral appliance in a proper dimension into people's mouth.
What does that even mean?
You have to put it into relation with the joint.
Why?
Because we're just learn to do it.
Yeah, right, exactly. Exactly. It reminds me, when I tell the story, Alex, when I was in dental school. I was a freshman in dental school, and I walked into the dental lab, and there was a guy I knew nothing, not claiming I know anything now, but I knew nothing, and there was a senior dental student mounting the case with a face bow. And I looked at him and I said, I never saw that before. And I just wondered, I said, so what are you doing? And he was very arrogant. Oh my God, this goddamn freshman, what does he know? He said, I'm mounting the case. I said, what is that? He says, a face bow. I said, well, what's its purpose? He said, well, it relates the upper model. And in my ignorance, it made no sense to me. I said, to what? And he looked at me with a straight face and he said, the universe.
Exactly.
I love that answer. That's good.
No.
You're still having trouble with that concept, Barry, all these years later.
It's a little problematic. Yeah.
So let's get real here, though, because Alexander just threw something out there. I think we owe him an explanation as to why this conversation has gone this way.
Okay.
So I'd like to understand, Alex, why is it that you're using a face bow you're saying before you fabricate a nylon appliance? Why would it be a nylon versus any other appliance?
Fabrication of oral appliances, of dentures, anyway you have to change vertical dimension, you should use a face bow. So
Make sure you capture the right cant and everything when you're opening up. Is that basically what you're talking about?
yes.
Okay. Okay, so if you're opening it up and you're taking a byte registration, just being sensitive to the fact you're not, distorting that cant, that's not good enough. You need to use a face bow to do it.
And
Alex, do me a favor.
yeah.
Do me a favor. I want you to write this down.
Okay.
Can you write this down?
Yeah, I can do that.
Okay, get a paper, get a pen. Get a piece of paper.
Just right now?
Yeah. You got to write this down.
Now, Barry, how about this? Why don't you email it to me and I'll email it to Alex. I've got his email. Because you might not have a pen. You might not
I
have
don't
a
think
pen.
what I'm going to tell him is allowed to go over state lines. No, what I want you, Alex, just John, send Alex my email, or get me
I will. Yeah.
email, and I'll send you some lit to read
Literature.
about.
Yeah.
Some updated stuff, some stuff from Manfredini, some from Lobozo, and some really good people talking about exactly what you're referring to, and maybe just give you another.
And that could be a future discussion, actually, in more detail. Yeah. Okay. Any other questions there, Elaine? I see some stuff in the chat. No, nothing. Everything's been addressed.
Did I miss an exciting session?
I know how much you're into nylon appliances, so I'm surprised. I'm glad you joined in when you did, though.
No, I'm dealing with the decision on whether to take the payment protection plan given to the United States with my theater, and so it's not an easy decision. Great. Did we talk about the Remmers thing? Was interesting. It's a good way, I think, maybe to spend a few minutes. Is the Matrix, Alex? Is a Matrix or Matrix Plus ever? I wouldn't think that it would be very relevant in Germany, knowing your patterns of practice there. I wouldn't think that it. No.
Not yet.
No, I don't think it will be because there are some major issues with patterns of practice, and there's some real good reason and logic to its use in terms of deciding whether just think about the advantage of not only determining whether or not how well someone is likely to respond, but also where to put them to respond there. And based on a whole bunch of parameters that is very complicated and really is AI at its best. But the issue is still economics, and they haven't. It hasn't been, and I don't think is going to get resolved. And so it's sad because it's really good. It's really solid instrumentation. It's really solidly based in terms of advantages and disadvantages of using it. But it's if you get a chance, Alex, it's worth. If you're not familiar with it, it would be worth picking up that, looking at that at Remmer's presentation from Monday, from yesterday. It was really good.
No, Alex was on it, I think.
Oh, were you? Oh,
Alex, you were on it yesterday, right, with Dr. Remmer?
Alex, what was your impression?
Yeah.
What was your thought process of that presentation and the use of the matrix?
You're asking me?
Yeah, I sure am.
Okay. Well, I know the matrix system for long ago, and they use it in the Netherlands. I don't know were there any European countries using it at the moment.
I don't think so. I don't think so. It doesn't fit. I guarantee you, England isn't.
2 years ago, I was talking to Suresh in Amsterdam, and I think he brought some of those things over to the Dutch Society Dental Sleep. I haven't heard of any results.
I wouldn't think so. Though it makes there's some real good reason. It gets back to, and it's interesting because it all depends. There's so many different practice pattern models throughout the world, and I think we've made some major mistakes as physicians and dentists in terms of dealing with sleep. And I think it makes, to be honest with you, after all that I've been through, and I think John might agree with me, and the other John might agree with me, I think that it makes a lot of sense, would have made more sense, not necessarily to have a specialization, but to have not look at this as an individual dental practitioner doing, his 2 or 3 appliances sort of haphazardly when they come up. But if we had a dentist in your region, Alex, or a dentist, and John was the dentist of Toronto, and I was the dentist in Allentown, and so we concentrated, and that was our practice. I think several things would have happened, and we were tied directly with physicians. I think we would have had better physician relationships. We would have had more choices made in terms of the best treatment for patients rather than the best treatment I can give the patient because I'm, in a uniform way. We could have taken additional. We wouldn't have had people applying for $8,000 for appliances, which is what we've got some insurance companies paying in some cases, and some not paying at all. We would have had improved care, improved communication, and we would have had improved access to care with our patient base. That didn't happen, and so we've got all of these industries making money by getting dentists involved as much as we can get them involved, even though we know in the long run there's a good chance many of them aren't going to be successful. So it's kind of sad. And there was a better way to do this, but we all entered as dentists of an already broken system, and so leave it to us to have broken it further. Who is that? Is that Laurie? Who do I see?
Who's that?
That is Laurie, is it?
Yes, it's me. I'm listening and learning a lot from you folk. Thank you very much.
Good to see you, Laurie. Great.
Thank you.
Yeah. Well, it is now 4:50. I think Barry did a good sum up on our current status of dental sleep medicine.
It's true.
Yeah. So next Wednesday, we're going to be talking about OSA, oral appliance selection. And I think it's going to be very conducive, that discussion, to a whole bunch of sharing, because, all of you as individuals have, I'm going to say, I don't like this term, but your go-to appliances. I'm not going to say appliance, but, your selection of appliances that you'd like to go to that take care of the patients as they present in your practice. And so I think we can all learn a lot from each other with regards to what everybody's doing. So the way I'll handle it basically is we're gonna basically put up a slide that shows a particular appliance design, and then all the appliances that fall in that design, and then we can talk about that design and how everybody can share about how they use it, don't use it, like about it, don't like about, what to watch for, and so forth. So by the time we go through that exercise and we go through all the different potential designs, I think we'll all, including myself, have some good takeaway points that we'll have shared with each other.
Hey, John.
Yes,
John,
sir. Yeah.
Why don't we ask the few that are here?
Yeah.
If there's a particular appliance that is your go-to appliance that you would like to take the lead on discussing, just email John.
Yes.
And then he can prepare. You don't need a presentation. It doesn't need slides.
No, basically, I'm going to be using slides from when I teach oral appliance anatomy, but the slides just going to go up. And so that's the design. And then
Yeah.
after whoever says, I want to talk about the dorsal, fine, email me, and you can be sort of presenting on that, give us your thoughts, and then we can share. The idea here, hopefully, is that everybody can sort of share their ideas on that dorsal design.
Right. So, but this would be the person who would take the lead. Take the
Yeah.
lead and
Yeah.
give the first 5
Yeah.
minutes. You know,
Yeah.
10 minutes of talking about it, why they liked it, etc.
Yeah.
And then when they didn't use it, not, you know, whatever. So if there's an appliance that it's your go-to appliance,
Yeah.
just email John at drviviano.com. Does that work?
That's right. It's right on the screen there. Yep. Yeah.
Ah,
Yeah, so that'd be great. I think that's a great idea, Barry. And what I think we can all really benefit from hearing what we all do, you know, and even if you walk away from that with 2 or 3 pearls, that'll be very helpful.
Great.
So listen, thank you very much. It's our 3rd session. Looking forward to next Wednesday already. And of course, I can't say goodbye without, you know, once again, sending my heartfelt thank you to all of the people on the front lines. Even, let's take it out even to the people at the grocery stores, you know, working at the cashier, everybody that's out there in the world, you know, doing what they have to do in order for us to have food and stay safe and so forth. Well, we're at home self-isolating. I'm so thankful for all their efforts, and I think I know that you all feel that way, so I just want to send that thank you out to everybody. Thank you, folks, very much. We're winding up just about 7 minutes early, and unless there's any last thoughts anybody wants to say.
Just thanks, everybody. It's good.
Okay.
Yeah. Sorry, Ashok Sabu Rama just wrote, thank you, everybody. Good info. And that's it. Adrian.
Hi, Adrian.
This will be archived because we actually recorded it this time around.
That's right. Elaine reminded me. Yes.
Yeah. You were going to give me hack because I texted you and distracted you. I saw that.
Yeah. No, it was important.
Yes.
See, with GoToWebinar, it automatically records. For the GoToMeeting, I actually have to go and press the button. And so 3 weeks in a row, I've forgotten to go and press the button. So I got better this time.
This time
95% of it archived. So
you forgot about it too today.
Absolutely. Yeah.
But anyway, both sessions were recorded, Adrian. So they will be archived in the website.
Yeah. So Adrian, for the previous 2 weeks, I went and refilmed the slide portion of it anyway, that archived. And for the first week, actually, we did get a lot of the discussion. So if you're sitting at home looking for something to do, you can check it out. Once again, thank you all for attending.
y'all.
Have a safe week.
Thank you.
Okay. Ciao, everyone.
Bye-bye. Take care, everybody.
Thank you.
Bye, Alexander. See you next week.